Thank you, Manny. Hello, everyone, and thank you for joining us today. Let's get started. So the NCC has created 2 change packages, one for home and one for transplant. Each facility will be assigned to work from one change package over the next few months. In order to find out which change package you'll be working from, you'll want to check LMS on December 11th for your facility's assignment. Next slide, please. So what are the change packages? The change packages are a collection of proven methods used to improve performance with quality improvement activities. These methods were collected from top-performing dialysis facilities from across the country. These change packages are intended to support dialysis facilities to increase the number of patients using any home dialysis modality and increase the number of patients referred to transplant centers, evaluated for kidney transplantation, and placed on the transplant wait list. They can be used in your quality improvement meetings and interdisciplinary team discussions. The actionable change ideas found in the change packages are also known as drivers. These change ideas are designed to support and augment your current QI efforts and your tools. Many of your current corporate tools align very well with the change package drivers. Next slide, please. So CMS does have a few expectations for facilities when they use these change packages. They expect folks to identify areas of improvement, identify plans for sustainability of the improvements that they wish to achieve, measure the reach of each intervention that they're using. This includes if it reaches patients, if it reaches family, and then also measure the effectiveness of your quality improvement efforts and the efforts used in the change package. As time allows, you're also encouraged to continue to deploy different change ideas found in these change packages. Next slide. So over the next 3 months, each facility will be expected to select a primary and secondary driver. In December, your team will conduct a root cause analysis, discuss the results of this analysis in your December QAPI meeting, and then select a primary driver that can improve your quality results. As soon as your facility has decided on a primary driver, report this into LMS. In January, in your January QAPI meeting, you will need to select a secondary driver and report this into LMS. You will also need to develop a plan for the change that you wish to implement in February. So in February, facilities are going to be expected to implement the interventions they found in the secondary driver that apply to the primary driver they selected in December. Each change package is similar in format, but the interventions are different. And so we want to encourage everyone to consider using the techniques found in both change packages in all your QI efforts. But for now, focus on the ones that you're assigned to. So let's take a moment to learn a little bit more about the transplant change package. So as a reminder, if you're not sure which project your facility is assigned to, please log into LMS on December 11th. Next slide. So this image shows us the primary and the secondary drivers found in the transplant change package. There are 5 primary drivers and 16 secondary drivers. Before selecting a driver, conduct a root cause analysis and become familiar with all the drivers before your December QAPI meeting. Next slide. This slide provides us an example of a driver diagram developed with an aim, which is also known as a goal, and drivers from the transplant change package. Again, drivers are those different elements that help to move your improvement efforts forward. In this example, the facility would like to improve their kidney transplant referral rates by 30% in the next 90 days. Their root cause analysis revealed that their quality improvement efforts were sporadic. Some months they referred several patients, and other months they didn't refer any. After reviewing the change package in their QAPI meeting, they felt that the primary driver number 2 was the best fit for them to achieve the goals that they set in their aim, because it focuses on implementing a continuous quality improvement initiative. The change package tells us that successful facilities track patient referrals and document patient progress as part of their ongoing continuous quality improvement efforts. Upon further investigation, the example facility's root cause analysis, it was noted that they did not have a consistent method to track referrals for transplant and patient progress through the referral process. If tracking is inconsistent, the facility cannot accurately measure its progress towards a goal. Quality improvement cannot occur without measurements. So using the transplant change package, we can see on page 7, driver 2A recommends facilities track transplant referrals and progress. Before we get too far ahead with our example, let's take a moment to understand what steps are involved with selecting each level of driver. Next slide, please. So to select a primary driver, each facility should complete the following in their December QAPI. You want to examine your transplant performance and practices, conduct a root cause analysis, and if you've forgotten how to do that, we did an excellent recap in last month's Network Council Call webinar, which is available on the Network LMS. If you're not sure where to find that, feel free to email either one of us and we'll help you through that. The next step you want to do is you want to identify an improvement based on your root cause analysis results. It needs to be meaningful and it needs to be something that's achievable. Select a primary driver that matches the improvement goal. And then you'll need to report your primary driver selected into the Network LMS. And you'll want to do this as soon as you've identified that driver, but no later than January 10th. Next slide, please. Okay, so how do we select a secondary driver? Well, there's a few ground rules you can think of. First, you want to select a driver in January that can be implemented in February. But you also want to pick an intervention that's going to make a difference to patients. So as a team in January, you're going to review the secondary drivers associated with your primary driver that you selected in December. Just pick one. Develop an implementation plan and then report that selection into LMS. Think carefully when you're reviewing these secondary drivers about what systems and tools your facility already has in place and pick a driver that maybe adapts some of the systems and tools that you already have, but also is going to have a meaningful impact moving forward into the future. Next slide. So for each secondary driver, it contains various change ideas. These change ideas are more commonly referred to as interventions. When selecting a change idea to implement, select one that can help you achieve your current performance goals and one that can also be useful in the future as requirements change. In this image, we see that for the secondary driver, there are a lot of change ideas to choose from. We are only displaying 3 of the 6 found on page 7 in the transplant change package. Idea 1 tells us what metrics to track. Idea number 2 tells us what types of tools we can use to track referrals and patient progress. And idea number 3 provides us an example of how to use company tools such as EMR to document progress in weekly notes. I want everyone to remember to just keep it simple, but impactful for patients. And also, this isn't about checking a box. It's about really moving things forward through the future. So to follow our example from earlier, our facility needed to find a way to improve their tracking process for referrals and patient progress through the referral process. They recognized they had an opportunity to better utilize their existing technologies and company tools in their improvement efforts. So they've decided to move forward with change idea number 2, which offers some methods for this facility to try. So let's take a deeper look at change idea number 2A. Next slide. So for change idea 2A, recommends you, and 2A.2 recommends using electronic tools to track each patient's waitlist transplant status. This should include tracking referrals for transplant. It recommends making the tracking tool accessible to all staff. And since quality improvement is a team sport, it makes great sense to include all levels of staff in all levels of the care team with this effort. Because by doing this, it helps to build a pro-transplant culture and also helps improve consistency with the overall improvement effort. To do this may require this example facility to update their EMR documentation templates and some of the forms that they have or they are using to capture new data requirements. They also may need to do some training to ensure that all members of the care team have the permission to use the forms, but also understand how to use the forms. Our example facility may also want to look at what kind of spreadsheets they're currently using to track time-based metrics, like the date of a referral, or other metrics that highlight a patient's progress. The change package mentions documenting in free text notes. However, if you want to be able to analyze your progress, it's better to have your documentation set up so you can pull a report quickly. Data found in clinical notes requires a person to review it and to capture the important details in a separate log. This can take extra time and manpower that you perhaps don't have. So with short project cycles such as this one, it's important to be as efficient and as effective as possible. As you consider which change idea to implement, you and your team should discuss where certain types of data are stored. You can do this in your January QAPI meeting. I want to remind everyone that this isn't about reinventing the wheel. Consider reaching out to other dialysis clinics in your network for suggestions and ideas on what works best for them. For example, one clinic we spoke with requires their referral tracker be updated with each communication and also requires staff to communicate with the social worker or the RN about patient conversations pertaining to transplant. This included chairside conversations. Because they had this all-encompassing approach, they were able to improve their metrics quite substantially. Next slide, please. So quality improvement doesn't happen in a vacuum. There are many factors that may impact your results, so it's important to consider them as you continue with your efforts. Change ideas from other primary or secondary drivers may help you to be successful with implementing your chosen interventions. Our example facility could consider supplementing their efforts to track transplant referrals by incorporating the idea from primary driver number 1, D3, which suggests including discussions on referrals in the weekly staff meetings. If one change idea from another secondary driver might help you succeed, consider using it as a supplement. In later cycles of your improvement efforts, consider selecting multiple secondary drivers as a strategy. Just as we recommend reaching out to peers for ideas, don't forget about other external resources that may be available for you. Next slide, please. For example, you may want to consider using resources found on the ESRD NCC Kidney Hub and also the Network LMS Transplant Resource Book. So now that we've kind of got a better understanding of what is found in the Transplant Change Package, I'm going to hand it off to Jewel to give us a little more information on the Home Modality Change Package.
Thank you so much, Brianna. Thank you. Can we have the next slide, please? All right, so I'm going to start talking about the home change package. So like Brianna said, there are 2 versions of this package, one for home, one for transplant. And if you're wondering to yourself, well, which one am I concerned with? Just in 10 seconds, you can get that answer. Just log into LMS. You'll see which task is there. Is it home or is it transplant? And the next slide, please. The packages also, if you want to reference them, are posted inside LMS and attached to this invite. So first I want to talk about why are we so concerned with home. So if you're familiar with the ANA Code of Ethics, or if you've ever taken an ethics class before, you've no doubt seen this word, autonomy. It is Latin for self-rule and is the ethical principle behind a patient's right to self-determination. One of the ways we uphold this ethical principle is by ensuring our patients understand their modality options and their right to self-determine what is best for their quality of life. So we spend a lot of time educating and demonstrating the various modalities so they can make a truly informed decision. All this work for one very simple reason. We want our patients to be happy. Many of them are not happy with the modality they are currently on, and we wish we could provide some glimmer of hope or ray of sunshine to help, some better fit for their life. Next slide, please. So, as you know, more than 37 million people in the US suffer from kidney disease. It is the 9th leading cause of death as of 2017, and it costs an estimated $114 billion each year. Most patients crash into in-center and they express that they feel like they never get the chance to understand their other options. And this isn't fair to the patient. It's also not fair to the staff who are trying so hard to work with unhappy patients. Increasing home dialysis is a national priority, and dialysis facilities play a central role in helping more patients with ESRD understand their options. A concerted effort is needed in all kidney care to meet the lofty goals set by the Advancing American Kidney Health Initiative, by CMS's QI projects, such as this, by your company's initiatives, and by the upcoming ETC model in January. So no matter how you roll the dice, home modalities are going to be a push in your clinic in the coming year, if they aren't already. So how many of you would say that transitioning patients to home has zero problems, that you never experience a single hitch, and that patients fly through the system in just a few weeks to whatever their chosen modality is? If this is your experience, please call me so I can learn your amazing secret. I'm going to move forward on the assumption that you'd like to solve some of these headaches so you can worry about the much more pressing things on your plate. So with that in mind, CMS has provided us with the Home Change Package to help target our efforts more effectively based on the best practices of the people who are already successful. The point is not to transition all your patients to home immediately, although that would be great if it's realistic for you. But for us mere mortals, success is measured by demonstrating effort to improve current practices. The ideas in this package were taken from those high performer facilities across the nation. These best practices are meant to give you bite-sized steps to build a really strong program by asking yourselves, what can I do by next Tuesday to get this started? Next slide, please. All right, time is of the essence. So what exactly is expected with this change package in this webinar? Here is your timeline going forward. Yes, I will show this slide again later. In December, your IDT will be QAPI, just like usual. For the change package, you'll conduct a root cause analysis and you'll choose from the list of primary drivers listed in the change package. Remember, again, it's attached to this invite and also posted in LMS. Now, there are only 4 or 5 primary drivers to choose from, so this will not be a big list of options to pull from. They are meant to be broad categories that provide context. You'll next document your QAPI meeting and then log into LMS to choose which primary driver you chose. The task is literally just logging into LMS and picking which one of the 4 or 5, so it should not take more than 30 seconds to check that box off your list. Done and done. I love sweet and simple like that. Now in January, your IDT will get together and review your clinic's data, revisit the chosen primary driver, and yes, you can change your mind and choose a different one if you found some other data or something, no worries. Each of these primary drivers has 1 to 3 secondary drivers for your team to choose from. So you pick one and then pick a secondary driver from that very short list. make sure you choose from a secondary driver that is related to your primary driver, even if you change your primary driver. Then your team will pick an intervention from the list in the package, set a goal, create a plan. Easy peasy. The second task will ask you for the secondary driver you chose. So again, completing this should take no more than 30 seconds from the time you log into LMS. Okay, that was a quick overview. Let's go over it in a little more detail and look at some examples. Next slide, please. First step, once your clinic has picked a primary driver of change to work on in your QAPI, the next steps will help you create a robust plan. So next you'll pick your secondary driver, which is the reason behind the reason, also known as your root cause. You'll likely have more than one, but remember how we talked about having specific goals for QAPI. We're going to pick just one at a time. Next, you'll pick which intervention you want to try. You don't even have to think of anything. You don't have to come up with something, nothing outside the box, no innovation. I mean, I certainly encourage you to do so, but you don't have to. Time is of the essence, right? You can pick one off of the list that is related to your secondary driver, and you are ready to go. You'll monitor your intervention's progress in QAPI and revise as needed, and eventually in the future, you'll graduate from one cause to another over time as you see how things are going. Progress. So that's an overview of the entire process. Now let's look at the first step, choosing a primary driver. Next slide, please. Okay, so it's like a very long road trip, and one of you is going to do most of the driving. It's usually me. A primary driver provides the context for the root cause you'll identify. Your team will choose one to focus at a time. Okay, so under our home change package, we have 4 primary drivers to choose from. First, physicians. Did you know that before this year, nephrologists in training had 3 months set aside to learn about dialysis? Out of the 9 to 10 years of training they get, 3 months, and it only covered in-center. Do you have a nephrologist who seems uninterested in helping patients transition to home? You are not alone. Keep in mind that many of our nation's nephrologists received little to no training on home modalities unless they were lucky. Faced with the responsibility of managing the medical care of someone whose modality is completely alien to you, you can understand why so many nephrologists seem to be hesitant, but it's not their fault. And we can do our part to support them as they tackle a whole new set of medical skills in order to prescribe home modalities. Next, a change in culture and attitude. Number 2, when you go down your list of patients, does it seem like an endless list of I can't? Our personal bias can color our opinions negatively until we've painted ourselves into a corner. As care providers, we must be honest with ourselves for the benefit of our patients. You may find that it's a good idea to work on positivity and confidence of your staff. Learn how to say yes at every turn. Learn how to say I can to open up new roads and options for your patients. Number 3, home modality training is an exercise in care coordination. And as we know from hospitals and nursing homes, care coordination takes really good communication, or it can go south really fast. So working with your home partner on better workflow and communication will make everyone's life easier, including your patients. Finally, number 4, continuous patient and caregiver support is about finding ways you can help them achieve their goals for their quality of life. It's about diving into their individual factors. We already provide continuous support, right? But not in this context. This is about being innovative and thinking outside the box to troubleshoot whatever barriers they face with your team. Next slide, please. So that's your December. So again, your December QAPI meeting will involve your IDT reviewing your data to identify a root cause, pick a primary driver from the change package, like what we just talked about. Don't forget to document your discussion in your QAPI file. Whether you keep a binder or have a fancy dashboard, just make sure it's mentioned in there. This doesn't need to be an essay, so we're going to look at examples to simplify your QAPI documentation on this entire process. Next slide, please. In December, your QAPI documentation on the change package should be at least 2 sentences. The first sentence covers what you did and when. That's pretty straightforward. The second sentence spells out that your team identified a root cause. And when you write this sentence, make sure you don't just put, "We chose number 3." Include the entire sentence from the change package, because a year from now, when a surveyor asks you, "Okay, what was number 3?" you'll have no idea. So just put the quote in there. All right, next slide, please. Okay, so with December wrapped up, you've picked a primary driver of change, and now you're going along in life and taking care of patients and kind of keeping an eye out for the situation at your clinic. Next, you'll pick your secondary driver. Again, the reason behind the reason, your root cause. You'll likely have more than one, but remember how we talked about having specific goals. So we want to be specific. We're going to pick just one at a time. Next, you'll pick what intervention you want to try. And again, you don't have to think of anything unless you want to. Great, encourage that. But you have a list there that comes pre-formed, best practices from top performing facilities across the nation. That's a pretty good list. And then you'll monitor your intervention's progress. Next slide, please. Okay, so choosing a secondary driver. Under the home change package, here is an example of how we could choose a secondary driver. So let's say in our clinic, we decided that the primary driver, the first one, is kind of our area of weakness and probably the best place that we could impact home modality transitions in our clinic. Now, this is an issue of leadership. Having a physician support home dialysis, since they are the leader of the IDT, it's important that your boat has a captain, right? And if that's what your clinic is suffering from, what are some ways that you get the captain to, move the steering wheel or whatever a boat has? I don't know. Okay, so under this primary driver of physician leadership, we have 2 different secondary drivers. First, strengthen nephrologist comfort level with dialysis at home. Just remember that nephrologists, again, are the captains of successful home dialysis programs and are at the heart of dialysis education and prescribing choices. Strong home dialysis programs have a physician champion who is essential to a positive home dialysis culture within your facility. Second secondary driver to choose from, improve primary care and specialty physician awareness and education. So this is about outreach. So this is not just the nephrologists immediate to us, but all those primary care physicians that we like to say, "Oh, I wish they would work with their stage 3 and do better." This is your opportunity to do that. More physicians need to understand the benefits of home dialysis to help increase the use of this modality. This is important as physicians have a central role in patient education and decision-making. Successful home programs have taken the lead to educate everyone about home dialysis, including those folks who are kind of satellite to us. Next slide, please. So after we've chosen a secondary driver, we're going to next choose an intervention. We're all familiar, of course, with implementing interventions for patients, for QI, etc. Keep in mind the change package uses a fancy term, change idea, but it just means intervention. Same thing. There are tables and tables of interventions in the change package, and this can seem overwhelming, but just back up for a second. Okay, you chose a primary driver, and then you chose a secondary driver that is only related to that primary driver, right? So choosing an intervention is the same. There is a table that is specific to your chosen secondary driver. Find that one table, pull out that page for your IDT to look at, and save all the other pages for future use, somewhere down the line. So the sequence here is pick one primary, pick one secondary, pick one intervention, pick one, pick one, pick one. Keep it simple, as they say. Can you do more? Sure, great. Just remember, you and your team have a lot to do already. So your clinic will be more successful and effective if you just focus on one baby step at a time. Okay, choosing an intervention. Here is an example from the Home Change Project. So if we chose primary driver number 2, adopt a mindset that home dialysis is possible, this is about culture change at the clinic. And the secondary driver that we could choose is consider all patients, widely refer patients. Well, you can read it. I don't need to read it to you. And then you would find the table that is specific to 2B here. And there's a long list there, and you could pick any one. You could pick one that sounds good. You could pick the first one on the list. You could pick the last one on the list. Whatever makes you happy. I shouldn't say that. Whatever is most impactful for your patients and your situation at your clinic, which would also make you happy, I'm sure. Next slide, please. All right, so again, we're talking about January and your QAPI meeting in January. So of course, first step, schedule it, obviously. So again, your QAPI meeting will involve your IDT, reviewing your data and your primary driver that you had already chosen. Now you're going to choose a secondary driver. You're going to create a goal, because obviously you want to get somewhere. Your primary driver is driving that car to where? Chicago. Great. Create a goal, form a plan. Don't forget to document your discussion in your QAPI file once again. And still, documentation, even for January, can be very simple. So we're going to look at an example for your QAPI documentation. Next slide, please. All right, January. In January, your QAPI documentation on the change package should be at least 3 sentences. The first sentence, again, covers what you did and when. Again, pretty straightforward. The second sentence spells out that your team identified as your secondary driver, what your team identified, and what the intervention is. So that looks like a long sentence, but remember, we're going to use the entire sentence from the change package because we're not going to know what they are in a year if we just say, we chose 3B. So spell all that out. The third sentence is your goal. Now you guys decide what is an appropriate goal based on what is realistic for your situation, but just make sure that your improvement is specific and clearly stated in numbers. Not just we'll do better, but we'll do 10% better than last January, for example. Whatever's appropriate for your situation. Next slide, please. Finally, you'll carry over this process into the future. So imagine this arrow is like a wheel. It just keeps rolling on and repeating itself. Makes it very easy. You can use the very low maintenance change package indefinitely to pick new ideas for improvement and implement best practices 20 years in the future. Don't quote me on the 20 years. Next step, please. Next slide, excuse me. So before we wrap up, a couple quick notes about LMS. If you need to log in for your clinic, please contact our data department for assistance. Their email address is listed there. Remember that each task is monthly, and that doesn't just go for the change package, that's for everything. So for example, your December task, so your December QAPI, you pick a primary driver, your December task will be due no later than January 10th. And this is true of any task in there. And then again, your January QAPI, that January task will be due no later than February 10th. So the first task will go live December 11th. That's next Friday. So once you have your QAPI meeting, log into LMS between December 11th and January 10th to complete it. Again, only 30 seconds and then done. Great, right? Next slide, please. Okay. A quick plug for anyone who doesn't already have a pre-formed template for their QAPI meeting. The ESRD forum has created a really great toolkit. It includes step-by-step instructions, forms, templates, a slide deck with a lot of details and education. If you don't specifically need to use this, I hear it is really great education. If you have a new medical director, hand him or her this. Print it out, hand it to them. Hey, here's your responsibility, your main responsibility there. Besides free lunch once a month, here's all the information we need to go over. Okay. Now, just a quick plug as well. The ESRD forum has actually a slew of toolkits that are really helpful for you guys. So while you're there, be sure to check it out. All right, next slide, please. Now, I promised you I would repeat this slide, and I did. I came through. This is your timeline once again. So at sake of, risk of repeating myself, December, QAPI, root cause, primary driver, due January 10th, no later than January 10th. Fabulous. January, in your January QAPI, review your data. Make sure you review which primary driver you picked. Are we going to stick with that? Pick a secondary driver that's related to our primary driver. Pick an intervention. Set a goal, implement a plan. LMS tests, no later than February 10th. Beautiful. Next slide, please. All right, that is the end of my section, and I would like to open it up for questions. I'm sure you guys have many.
So Joel, this is Barbara, and I'm going to start with some answers. This session has been recorded, and the session and the PowerPoint and the recording will be posted in LMS. Okay, so that knocks out a ton of questions. I am thrilled that you guys would like to use this presentation with your leadership team. So please be aware it will be posted in LMS. Here's an interesting question that I would like to address and allow Jewel and Brianna to add anything after I finish. I have read on different materials to encourage patients to accept a less than perfect kidney. Would you recommend that to a family member? Is it ethical to ask our patients to trust us and tell them it's okay to get less than a perfect kidney? So, and this came from an anonymous attendee, which is just fine. But let me say, absolutely anonymous attendee, I would recommend a less than perfect kidney to a family member. First off, how many perfect kidneys are going to be out there in the world, right? So instead of waiting 2 to 3 years on a wait list, you might be on a wait list for 20 or 30 years to get a perfect kidney, not to mention I'm not sure there really is a perfect kidney. Secondly, part of the reason a kidney might not be perfect is the age of the donor. And they are now, if you look at the prospective life of that graft organ versus the life of the patient actually getting it, it makes perfect sense for a 70-year-old to get a 70-year-old's kidney. Why should that 70-year-old wait around in hopes of getting a 20-year-old's kidney? The life expectancy is just not the same. Hepatitis C can now be cured after an organ is transplanted, and we now have incredibly accurate testing with PCR testing for HIV and hepatitis C. And I have heard directly from nephrologists that a lot of patients that OD or donors that OD have actually not done kidney damage. So there are a lot of things to consider. How bad is the drag on the patient's life to go to in-center dialysis or to do a home modality versus getting transplanted? And I will say I had some concern about this and have talked to our PAC members, which is our Patient Advisory Council. For anybody who's not aware, both networks have one. And I was surprised that every patient that I talked to that had a kidney transplant had actually taken a high-risk kidney. So not a perfect kidney. They were explained their options, they were explained the difference, and they all decided to go for it, and they're active on our PAC and doing very, very well. Jewel or Brianna, would you like to add anything to that not a perfect kidney question?
I think that's a really, really good question. And I think that as a nurse, it's like any option that I would present to my patient. You know, if I present them information about PD, for example, that doesn't mean I'm saying that PD is the absolute best thing for their life. I can't make that choice for them, but I can present them with the options that are available to them. The kidney is very similar. I could never make that choice for someone else, but I can certainly present that it is an option should they choose that that's good for them. I can see both sides of it, so I don't think there's really a wrong answer whether a patient should or should not get a kidney that's less than 100% perfect. I will share, I have a funny story about one patient when I was at a transplant conference. This patient, the issue came up and it was being discussed on stage by experts, nurses and doctors in transplant as an ethical issue. And a patient stood up and she said, you really can't decide this for me. I would take an HIV kidney over in-center dialysis any day. So, and again, that's just that one person. She's decided what is best for her body. But I think that's really the crux of it, is that it is a personal choice. We can present the options and let them know this is one of your multiple choice answers that you can choose from, and you can change your mind later if you want. Well, obviously not after the kidney is placed.
Yeah, this is Brianna. I definitely agree that you both have summarized, it's all about making an informed choice, and we give our patients all the information they can in a way that they can really understand it. And certainly if there's a question that you're not able to answer, or you're just looking for more information on what is a less than perfect kidney and what information is really best for me to share, please feel free to reach out to us. We'll help you find resources and help you to connect to other folks that maybe can help you answer those questions.
So another question along the transplant line, and Marie, holy cow, am I not going to answer this question? So I was just wondered, when a patient passed away from COVID-19, are her kidneys eligible to be transplanted to an ESRD patient? Marie, I have absolutely no idea whatsoever, but that is something we can reach out to the transplant nephrologists that work with us and ask. But I am not so sure anyone truly has the answer for that question right now. Okay, give me a second, guys. I'm scanning. Because I have to go through the chat and through the questions. Okay, a couple of questions that I do want to answer is, somebody asked, are these the only tests that will be in LMS? No, there are other tests in LMS. There is a monthly task that everyone has about how many home dialysis patients that you have are receiving treatment in the nursing home. This means that you actually have staff members going out and performing that home dialysis. That is required by CMS. Most of you will answer no. It is a 2-second ask. And there are other tasks. Please check every single month to see what you are assigned and handle those assignments as they come up. We do our best to keep them short and sweet for you. By the way, team, we did get a I love LMS comment in the chat. Thank you very much. Our data department works incredibly hard on it. And Jerry, no specific goals for this other than to keep home modality moving. So we are not looking for a specific target. We are looking for positive movement. There is a question again, and I'll just reiterate about how do I know if you need to participate. If you receive the email, you probably need to participate. And the task will be in LMS on December 11th for you. By the 11th of the month, unless it happens to fall on a weekend, your tasks are assigned. I am not seeing any other questions. Please feel free to drop them into chat or to answer the question through the Q&A section. And by all means, my backup people, if I missed something, please let me know.
The change packages are already available in LMS, so you could start reading through them and working on it.
In case Svetlana was very soft for other people, she was a little soft to me. She did say the change packages are up in LMS. They were also sent to the FA of record for the Network Council meeting last week. So we do have a question about if a patient leaves your facility to go train somewhere else, would it show that you had a positive change? Under Crown Web, it absolutely would. I am totally sorry to say under EQRS, we hope so, but EQRS is new to us just like it is to you. So keep your fingers crossed and hopefully this is the case. If it is not, we will work with you guys. All right, so COVID is rampant everywhere. Please, everybody, stay safe out there. Thank you and have a great day.
Thank you and stay safe, everyone.